you hear me? First, I'd really like to thank the Alliance for inviting me out, and two, for getting, like last night, getting to meet all the families and parents, something I don't often get to do. And I often say that if you know the name of your anesthesiologist, it probably means something went wrong, but it was very nice getting to meet all the families and kids. So for my talk, I'm going to primarily refer to children with MSMDS. Like many of the talks, this can also be applied to other kids with or adults with ACTA2 mutations. Our experience is with 4 children with MSMDS with a 179 mutation, and their ages range from a day old to 15 years old. Before this, there was no really any publications or any information out there about anesthesia and these children. So what we do in those situations is we really rely on kind of clinical expertise and ideally multi-center, multi-clinician expertise. I have no conflicts of interest. So we all know that children with MSMDS have complex physiology. So the effects of anesthesia really interact with many aspects of these kids' physiology and puts them at increased risk of complications under anesthesia. Just for instance, just the diagnosis of pulmonary hypertension increases your risk of a complication under anesthesia by about 20 times compared to a kid without. And that's not even taking into consideration pulmonary problems or Moya-Moya disease or other things. So one of our biggest concerns is the effect of anesthesia on blood pressure, and primarily, most importantly, the brain. Really, our body has, I'm going to go on a little tangent about blood pressure, but our body has 2 determinants of blood pressure: the force or the pumping of your heart, and then the vascular tone or the tension that your blood vessels make, which we know is the problem that these children have difficulty with. One other thing I like to point out about blood pressure is, and it's also shown in our work, is, your blood pressure has I'm sure you're all aware of this, your systolic blood pressure, your blood pressure when your heart is pumping, your diastolic blood pressure, which is usually determined by that vascular tone, and then kind of your average blood pressure between that. One of the things I've been trying to teach people on is automatic blood pressure cuffs. Which are great because they're the ease of use and the frequency. But those blood pressure cuffs determine your mean arterial blood pressure. And from that, it uses an equation or an algorithm to determine your diastolic blood pressure as well as the systolic blood pressure. And in these children, those numbers are very often wrong. And our work showed that for our kids that had an arterial line. So one of the things I like to advocate on is getting multiple blood pressures, using manual blood pressures, using arterial lines, because in the pediatric world, we often define low blood pressure by the systolic blood pressure, which tends to be inaccurate in these children. Sorry, that was my tangent on blood pressure. So MSMDS and anesthesia. So anesthesia is going to affect, essentially, it completely disrupts your homeostasis. So cardiovascular, nearly every anesthetic agent we use drops your blood pressure, and many of them also decrease the function of your heart. Respiratory-wise, when we sedate you, it causes atelectasis or collapse of your small airways, and then in kids with tracheobronchomalacia, will also cause collapse of their larger airways. If they have reactive airway disease, it increases the chances of having exacerbations with that, particularly in cases where we have to instrument the airway or put a breathing tube in. Gastrointestinal, it slows down the function of your gut. Many of these kids always already have slow gut motility, and that increases your risk of aspiration or throwing up under anesthesia, which can get into your lungs and cause further problems like pneumonitis. And then most importantly, neurologically, anesthetics, all your organs, in particular your brain, auto-regulate. There's a system of supply and demand as far as blood flow and oxygenation. And nearly all anesthetic agents disrupt that homeostasis of that and uncouple that autoregulation. Moving on, so given the nature, and you are all aware of this, of MSMDS, these kids are likely to require multiple anesthetics in their life. For the parents, how many of your kids have had more anesthetics than they've had birthdays? And it's pretty universal. You know, they're going to need anesthetics for their procedures, PDA repairs, their urological procedures, PICC lines, Moya procedures, aortic. And then also unique to these kids is they often need anesthesia for their imaging and their surveillance, whether that's echoes, CTs, or MRIs. So we kind of have a perfect storm of kids that are at very high risk for complications under anesthesia and who are going to need anesthesia quite a bit. So really, in order to provide the best care for these kids, the anesthesiologists or the people taking care of these kids really need to be aware of the implications of their pathophysiology and what anesthesia is going to do to that. One other small tangent. When I say anesthesia, what I refer to, primarily we think of general anesthesia. There's, you know, a spectrum of sedation and anesthesia. Usually for children, for most of this, we're discussing general anesthesia. And what I mean by general anesthesia, some people will say, you know, we're just going to try to deeply sedate the kid, or if your child is at a state of consciousness where you cannot wake them up, even if they don't have a breathing tube in or a breathing device in, that's general anesthesia. So when we discuss, when anesthesiologists tend to think of perioperative care or periprocedural care as the preoperative management, the intraoperative management, and the postoperative management. I would say that the majority of our work and the most important work is done in the preoperative management, because whatever we can do to set up for success is going to be give us the ability to give the safest anesthetic. Some of the things we want to address preoperatively are looking at the medications your child is on. Most of these kids are on an ACE or an ARB. We would typically ask that to be held if it's a once-a-day medicine the night before, the day before, or the night before if it's a twice-a-day medicine. The reason is it's only our anesthetic is going to drop their blood pressure, and this is only going to increase that. And I can give an ACE or an ARB, but it's very difficult for me to take it away. Some kids are on blood thinners. That should be a discussion with the surgeon and the procedural team about what to do with that. Pulmonary medications, we'd usually recommend that these be continued if they're on inhalers. Steroids, sildenafil, anti-pulmonary hypertension meds. Anti-seizure meds or anti-epileptic should be kept perioperatively as well. And then all these need to be systematically discussed with your anesthesiologist, the primary team, all the caregivers to make sure we have a plan for every one of those medications. The next thing to really address is the NPO time, or the nil pros time. My hope is that the days of telling parents, don't give your child anything to eat or drink after midnight, the day before their procedure, is done. It's pretty much universally considered that clear liquids up until about 2 hours before the procedure is not going to increase their risk of aspiration, assuming it's just a kind of a standard procedure, not on the bowel or the abdomen. The reason is we all know that these kids can get dangerously hypotense if they become dehydrated. So as parents, other things to do, if this is an outpatient procedure, I always tell them prepare for the possibility of an overnight stay. If it's an inpatient procedure, prepare for the possibility of going to the ICU. Things you can do if you're coming in from home, bring all their medications is a great one, because occasionally they can be on rarer medications that hospitals may not have access to. Bring oxygen for transport home, bring, if they're on a CPAP machine, bring that. All those things make our job easier, and also often give us the ability to get the kid back to what they're used to. One other thing on NPO is I often recommend when these kids are coming in, if they're coming in for MRIs or procedures, I ask that they be the first case of the day so we know that their case isn't going to get pushed back and they're going to end up more and more dehydrated throughout the day. So morning of surgery, we discussed a little bit about blood pressure cuffs. One of my big pet peeves is when these children come in and they get tossed in the room and the preoperative nurse, the kid puts them in a gown, the kid's screaming, they've been in the hospital numerous times, they don't want to be there, and the nurse takes their blood pressure right then as the kid's hysterical. And I get a blood pressure that I know is not, one, it's not an accurate blood pressure, and it's certainly not their baseline blood pressure. So what I ask is that they get the children calm, yeah, get the children calm, give them time and take multiple. I usually ask for at least 3 blood pressures, and if possible, get a manual blood pressure and compare it to what the blood pressure on the automatic cuff gives. These children have been in the hospital numerous times. They know it's not a fun time, particularly when they know they're coming for a procedure. So they tend to be very anxious. I'd say 95% of children that have multiple hospital encounters get some peri-procedural anxiety. There is that 5% that somehow like the hospital is like their favorite place to be. And they're like, I'm fine with that IV. That's very, very rare. But so for these children, things like child life services or distractions are really invaluable as far as getting them back to the operating room safely. And then if needed, we have pre-medications as long as they're monitored and in a safe way administered to help give some anxiolysis before we take them back. And then as parents, you should really have a discussion with your anesthesiologist. Make sure that one, that they're aware of what their diagnosis is. Encourage them to communicate with their specialist, with their pulmonologist, their cardiologist, their neurologist. Let them know of, as we've said, let them know of any changes in their medical history, cough, recent cough, colds, fevers. Those are all things that are going to increase their risk under anesthesia. Make sure they're aware if your child has any neurological deficits, so we have a baseline to know what to look for any changes. And then come up with a plan. You know your child best about how he or she is going to go to sleep best, whether that's with an IV or going back and going to sleep with anesthesia through a mask. So as far as the anesthetic plan, it really needs to be tailored to the patient and to the procedure. I certainly have found, looking at our data, there's really no one recipe that's going to be perfect. What I really advocate for is what we refer to as a balanced anesthetic. Every anesthetic medicine is going to have side effects, and the way to mitigate those is, rather than using a lot of one medicine, is to use a little of multiple medicines. And utilizing that, you can usually get your goals with the biggest or the smallest disruptions to their homeostasis and their homeostasis and their blood pressure. Refer to prior anesthetics. I recommend looking back and let your anesthesiologist, if this is your child's 4th time getting a PICC line under anesthesia, say what worked the previous times, and we kind of discussed. And that may change as the child gets older, but it's always good to have an idea of what has worked and what hasn't worked. Certain medicines, propofol and midazolam, some children will have really paradoxical or opposite reactions to what we expect. And you'll have the best information on that. So our goals intraoperatively are, number one, are to maintain blood pressure. I have a very short threshold to put in an arterial line for a longer procedure or an invasive blood pressure. That way I can have very tight, strict control of their blood pressure. Realizing that the risk of that is dissection or problems with the vessel, but utilizing smaller catheters than you would expect tends to be very safe, and removing the arterial line as soon as you can afterwards to prevent any thrombosis. And then looking at what you can for indices of end organ perfusion. How do we know that all the organs are getting? We could watch urine output. We'll put in Foley catheters. We now have cerebral oximetry or NIRS, where just similar to a pulse ox, we can see the oxygenation of the blood and look in the brain and look for changes in that. For longer or more complex procedures, there's even further neurological monitoring that we can do that may require a little bit more setup, such as EEG or things like that. that can be set up for longer procedures similar to like cardiac procedures. And then really our number one goal is obviously to maintain perfusion of the brain and prevent stroke, doing whatever we can to maintain that autoregulation with additional monitoring, keeping their blood pressure up. Watch when we take control of their ventilation, making sure that our ventilatory parameters are what's best for the brain. So I like to say one of my other jobs is a doctor of preventative anesthesia. So the safest anesthetic really for your children is no anesthetic. So really preventing unnecessary exposure to anesthesia. With so many caregivers, there's so many different teams taking care of these children. There can also often be the situation where multiple anesthetics that could be combined kind of get missed because everyone's just putting, well, we need a PICC line, we need a brain MRI, we need an echo. Let's try to combine all these into one anesthetic and work in tandem to prevent undue risk to these kids and adults. And then as children get older, really the goal, particularly for their imaging procedures, should be to get them through this without anesthesia. Child life services, distraction, parental counseling, parental help, whatever we can do to really get these kids off of sedation and anesthesia for their MRIs and echoes as soon as possible is really the goal, whether that requires just giving some oral medicine before they go into the MRI scanner. Post-operative management, and this really is all, and every time has kind of been a game time decision. So where to go? Is this kiddo safe to go home? Should they be brought inpatient? In our study, we saw that the most common reason for a kid to be unexpectedly have to be admitted is a respiratory problem. They just can't maintain their oxygen. And then if they end up in the ICU unexpectedly, the most common reason was inability to maintain their blood pressure. I have a very short threshold as well for most of these kids, even for something like an MRI, is I just start them on an infusion of a blood pressure medication, knowing that my anesthesia is going to drop their blood pressure. And if the risk benefit of just giving a little bit of a blood pressure medicine throughout to maintain them at their blood pressure is extremely worth it. And then anecdotally for the clinicians or for the parents as well, we've found that many of our kids require multiple blood pressure agents, and it seems to be arginine vasopressin seems to be the one that they respond best to. And it's nice because it can also be given in a peripheral IV, and it really takes the autonomic nervous system kind of out of the equation. So post-operative management, whether this kid's in the PACU, in the ICU, or on the floor, things to look out for that you are always looking out for, signs and symptoms of stroke. We've already kind of discussed how some of those can be a little bit different. Really serve as the voice. You guys are all wonderful at that. Any concerns, bring them to the PACU, the PICU, your anesthesiologist. Also, as a side note, make sure that everyone is aware of what your child's eyes look like, because we have had 2 code strokes called on children coming out of anesthesia due to a transfer of care. And that gets everyone very excited. And yeah, the pupils, yeah, they come out and they're like, oh my gosh, they've got blown pupils, they've herniated after a procedure. So yes, make sure that everyone is aware. Looking out, the other thing to look out for is breathing difficulties after anesthesia. I always tell parents to expect a higher oxygen or higher CPAP need for the next 24 hours after anesthesia. And then building on to what Dr. Carroll said is advocating for your child, really as you are none of us are your child's primary care person, right? You are the primary caretaker of your child. You know them best, you know what works. If an anesthetic has worked or if something didn't work that time, let your anesthesiologist know. And even more importantly, make sure they document it because there's a lot of anesthesiologists that may be taking care of. And if it's not documented, it may be very difficult to remember. So if things don't work, raise your voice and make sure it's aware for next time. Really, everyone has the same goals. Our goals are all to provide the safest care for your children. We recognize that you are literally handing us over like your child that you would die for, and we're going to take that away, and you expect us to keep them safe. So that's it. There was one slide that somehow didn't make it in, but I'll show you. It's in our paper, but it essentially showed in our experience, in our 3 kids, 30 anesthetics, when they're under anesthesia, their blood pressure drops about an average of 40%. So a huge significant drop under anesthesia. And that's cases with complete general anesthesia or with propofol and a natural airway. So if anyone's interested, this is that paper. It's got all our recommendations and pretty much summarizes everything in here.